our colleague Dr. Hilda will be talking about keratoplasty in keratoconus.
Good morning all, and thank you Sanjana for this opportunity. Keratoconus was first described in 1736 and Pickford had then told its intractable nature and fatal to vision. The pathology and treatment are so little understood. Around 289 years later, keratoconus still remains as an enigmatic disease. With the prevalence what we have, keratoconus, even in the British Journal in 2012 was told, was one of the most common indication for keratoplasty. In a span of 2 decades, there's a big paradigmic shift which has occurred, and no more keratoconus is the first indication for keratoplasty. And the decreasing trend is mainly because of early detection of diseases, routine eye screening by optometrists and ophthalmologists in the community, good control of ocular allergy, implementation of collagen cross-linking. With all these you have in hand, the risk of disease progression is reduced, and also the chance of acute eye drops is reduced. And we have n number of CXL procedures, and Sanjana also explained about CARES. And when you have all that, keratoplasty come last in hand and in your thoughts. And you think this is the end, but still you have gene therapy taking over, gene targeting keratoconus and halting the disease progression. And once gene therapy has taken over, no more keratoconus will be an indication for keratoplasty. So all the matters what we see today are the present, and very soon it's going to be in the past once gene therapy takes over. In spite of all the modalities, we have 20% of our patients will end up in keratoplasty as reviewed in journal 2023. However, the disease often affects the eyes asymmetrically. Many affected individuals remain asymptomatic until one eye is significantly affected. That is, most of our patients who come to us can be saved with CXL in one eye, but other eye would have gone for eye drops or scarring and will end up in keratoplasty. Very rarely you have both eyes going to keratoplasty nowadays. The king and queens of surgery are KP and DALC. Starting with KP, the indication will be full thickness corneal scarring, acute eye drops and perforation, extremely thin corneas. You have legends here operating on thin corneas, but when it is less than 150 and 200, it's quite difficult to do DALC. And when you have coexisting endothelial dysfunction. KP has very high success rate in keratoconus. The Australian study has shown 89% success rate in 10 years and 49% in 20 years. This is a keratoplasty I had done in 2023 in right eye with BCVA maintained well, and in the left eye post C3R. This photo, the keratoplasty was done at Little Flower 40 years back, and recently I had done phaco in the patient. I just put this photo to show how good the graft survives in spite of 40 years. It's very easy to identify olden keratoplasty because the grafts are pretty small those days. In spite of good results, we do have failures because of relatively younger age and greater lifetime. So you have greater chance of rejection and repeat grafts. The biggest villain which I face, I think most of them face, is glaucoma. The incidence of glaucoma is 9 to 35% post-keratoplasty. The one problem is it's difficult to measure IOP in the early stage because of irregular Myers, and even your disc changes may not be assessed. I would like to share one of the case. A 15-year-old boy had come to me with keratoconus both eyes, with left eye followed by eye drops and dense scar. Right eye I had done C3R in 2021. In 2022, I had done KP. Patient was doing fine for quite some time, but he came back to me after his annual exams and during vacation. By then, his IOP had spiked very high, and CDR also had changed. The problem with young kids and young adults, the disc changes occurs much faster than adults. The problem with glaucoma, when it starts appearing, when you start to interact it with anti-glaucomas, they do respond. But if your IOP is high for quite some time, they become very stubborn, and hardly they respond to the anti-glaucoma medication, and they'll end up in TRAB. So with glaucoma department, had done TRAB in 2024, and patient had developed PSC. I had done phaco in 2025. These are his fields, and you can see the peripheral fields are lost, and he has only tunnel vision. This is a photo of that patient. You can see supranasally well-looking bleb, beautiful graft, and IOL there. Vision, BCVA is maintained 612, but I'm very sure it's tunnel vision. The other problem we face with keratoplasty is post-keratoplasty astigmatism. The Australian study has shown 61% of the patients have to depend on spectacles and contact lenses after keratoplasty, out of which 77 patients had more than 5 diopters of astigmatism. The recurrence of ectasia is another problem, where you have anatomically clear graft but functionally not useful. You have recurrence most commonly as seen at graft-host junction, around 10 to 30% in 10 to 20 years. This is a photo of keratoplasty done at LF 27 years back in right and 35 years back in left. You can see here have similar ectasia which is occurring in both eyes. Patient has developed cataract, was planning cataract surgery and IOL later, with scleral contact lens later. The other cause of failure will be infected graft and failed graft. Coming to DALC, I'm not going to the procedure. As we all know, we have pre-response layer, Dovas layer exposure with big bubble and viscoelastics and fluids, and you have a manual dissection too. The surgery of choice is DALC always when your endothelium is clear and free of scarring. All the indication for KP will be contraindication for DALC. If you ask which is better, there is no doubt DALC is always superior than KP because it eliminates the endothelial problems of rejections and failure, lower risk of endophthalmitis, reduce the risk of complications, reduce the dependency of steroids and hence reduce the glaucoma occurrence, faster recovery, good graft-host junction, and a potential pool of donors increased because we are not even taking endothelium into consideration in this case. So you have more of donors. Friends, study have shown 3 times survival rate of DALC than KP. And it's a DALC done by Lailand, but when she was at LF, patient is under my follow-up now. 2014 and 19, BCVA maintained well. I put this photo mainly because the patient was steroid responder the right first week after keratoplasty, but still the patient survived and the graft survived with fluoromethalone and cyclosporin. Among the procedures of DALC, big bubble always stands superior than manual dissection in quality of vision and also the reduced aberrations because in manual dissection you have irregularities on the graft-source junction and even in the interface and can cause undesirable vision. DALC has a steep learning curve and surgeon dependent. Retrospective study also have shown the chance of perforations 45.4 and 24.1 and all this can be overcome when you have an intraoperative imaging and also femtosecond assisted. The graft-host interface is one extra thing which you have in DALC which is not there in KP. It can cause irregular blood vessels, inflammatory debris and also suture-related infections. Whatever said, it can never override the advantage of DALC. Now if the patient comes to you, what do you do next? For a case, a 46-year-old patient had come with keratoconus and C3R done both eyes. You can see the vision is counting fingers 2 meters and 1 meter with very high cylinders in both eyes. This is the pentacam results of right eye and as well as left eye. So before you jump into keratoplasty, the one thing which should cross your mind is the patient amblyopia because you don't know the patient was not wearing glasses and spectacles or contact lens for a very long time and you don't know when the keratoconus has occurred. So hang on, before you go for keratoplasty, do a scleral contact lens. When you put scleral contact lens, you have 2 things happening. One, if the patient is not improving vision, you can always explain to the patient after keratoplasty, this might be the vision you're going to get and the patient is amblyopia. If the patient is improving vision, you can buy time and get away with scleral contact lens itself. And also it gives an idea and anticipation what will be the vision if you do a KP in this patient. So scleral contact lens was given for both eyes. You can see 6/9 improved in both eyes and patient is not amblyopic. Other example, patient had come following high drops and dense scarring. This is the pentacam results of right eye and left eye. You can see both eyes keratoconus. Left eye I could get away with CXL and glasses. Right eye has advanced keratoconus with scarring. So scleral contact lens was advised. Patient had improved to 6/9. 1 year later, patient developed scleral contact lens induced infection with serratia emerescens but improved with moxifloxacin and tobramycin. Now what is your next plan? Patient after the infection is not willing to use contact lens. Patient wants a surgical treatment. So in that case, do your ASOCT, see the depth of scar and intensity of scar. If scar is very deep and DALC chance of perforation is high, in those cases KP will be better. The last example, a 42-year-old patient had come with 6/9 vision and 6/18. You can see the patient has cylindrical value more in left eye. And this is a slit lamp examination. And when you see slit lamp, when you focus on the endothelium, there are some gutties and vacuoles. So these are the pentacam results of right eye and left eye, showing keratoconus slightly in more of left eye. And these are the specular analysis. The genetic analysis of keratoconus as well as Fuchs endothelial dystrophy are 2 different patterns and it's very rare to occur. But I've seen around 5 to 6 cases with keratoconus with Fuchs as well as with posterior polymorphous dystrophy. So it's very important to check your endothelium before you plan a DALC. There are articles which has published keratoconus with Fuchs in 2021. Even in Kerala Journal of Ophthalmology, our own journal in last year, 2024, have shown the genetic connections with keratoconus and Fuchs, where identical twin was analyzed with gene mutation of ZEB1. So it's important to know both because in these 2, it can mask each other's. If your endothelium is slightly deranged, it can also change your pentacam results. So things which are steeper may not be steep. So conclusion, always think of keratoplasty last in your mind when you have all the modalities possible. DALC always stands superior for KP. In case you have any doubt, you can always plan DALC bar KP. That is, you plan for DALC. In case you go for perforation, keep your KP ready. Speak to the patient, understand the patient need, and customized treatment will be the best choice for the patient. Thank you.